Hello. A very good day to all the respected dignitaries and distinguished guests, esteemed speakers, and fellow participants present here today. I, Dr. Padmaja Bhapkar,
I, Dr. Neha Rathod,
feel privileged to stand before you as the coordinator of this session. We are thrilled to witness such enthusiastic participants and a highly learned audience gathered to deepen their understanding of this significant topic. I extend my humble gratitude to the organizing team of the Sushrutee 2024 for Ayurvedic Gynecology and Obstetrics. We now move towards the fourth session for the today. Seminar topic is application of hysteroscopy in management of infertility.
I would like to call upon the stage Dr. Anuja Kulkarni ma'am and Dr. Sharayu Gaikwad Wankhede ma'am to be the chairperson. I request Dr. Manda Khurpade ma'am to welcome our esteemed chairperson with a rose as a warm floral welcome.
I now heartily welcome our today's guest, Honorable Dr. Norman Gomez. We are very lucky and fortunate to have him between us today on the screen. As we all know his current surgical activity, he has performed 80 hysteroscopic procedures in 1 month, 120 laparoscopic surgeries in 1 year, 25 deep infiltrating endometriosis surgeries in 1 year. His experience in the field is consultant pelvic surgeon, Curon Hospital, Valencia, Spain, benign gynecologic surgeries, head of the surgical department, Equipo Medico, Crispo, Fertility Clinic, Spain, masters in mas- master in surgical management of deep infiltrating endometriosis.
I would now like to introduce our chairperson, Dr. Anuja Kulkarni ma'am. She is the professor and HOD at Bhima Shankar Ayurved College, Manchar, Pune. She has a total of 19 years of teaching experience. She has done her BMS from Shivaji University, Kolhapur in 1993. She has done her MS in Sri Rog Prasuti Tantra from University of Pune in 1998. She is a life member of Nima Obgy, KGOG, ABTC, and ATM. Our next chairperson is Dr. Sharayu Gaikwad Wankhede ma'am. She is the director of Vanchwell Infertility Treatment and Research Center, Amravati. She has done her MD in Sri Rog Prasuti Tantra, Pune, Maharashtra. She has done her MS in Assisted Reproductive Technology, Valencia, Spain. I would like to request Dr. Norman Gomez, sir, to start the session with the topic.
Ah, hola, doctor Norman. Hola, buenos días. No puedo oírle. Hola, ¿me puedes oír?
Hola, sí, te puedo oír. ¿Me podéis oír?
Hola, pues bienvenido.
Hola.
Bienvenido a Sushrutee.
Oh,
Estamos esperando para oírte. Está hablando doctora Sharayu desde Nima Obgy, Sociedad Sushrutee, Maharashtra, Pune. Y
no podéis oírme.
sí, estamos oyendo un poquito. Sí, puedes.
Oh, okay, perfect. So thanks to talk in Spanish. I will talk in English. I will try. The audio is good. It's good for you.
¿Puedes un poquito empezar tu un poquito
Yes,
más?
yes. Alto, más
Little,
alto.
yeah, little bit more your voice, please.
Okay. Let me see what.
Yeah, ahora está mejor. Yeah, gracias.
Okay, perfect. So, I'm sorry for the delay. I have to say thanks to the organizing committee for considering me to participate in this meeting. Here's the city where I live, and this is my workplace in Valencia. Valencia is located in the coast, this part of Spain, like this. And normally, let me, okay, so normally this is our team in our center. The name of the center is Juana Crespo. Juana Crespo is the name of the director of the center where I work. This is the staff of gynecologists there. This is the embryologist, and this is the surgical team. Okay, this is me with the anesthesiologist. In 2022, we have this surgical activity. We perform around 2,000 cycles per year, and our surgical activity is, as you can see here in numbers, is already 115 laparoscopic surgeries per year, more or less, and also 100 hysteroscopic procedures per year. This is the type of cycles that we perform with egg donation and with own eggs. This is the percentage. This is to inform you about at least our numbers in surgical. So my topic will be about the application of hysteroscopy in the management of infertility. So you must know that the approach of gynecological cases are slightly different than reproductive cases. Okay, so in general, you need to be more conservative in reproductive way. So the causes of infertility are diverse. There's a lot of cancers. Most of them are related with the female, and among the different cases, you can have already 12% represent a pure uterine factor. So the different etiologies that can worsen the prognosis in the patient can be this one in this list that you can see here. From the cervix until the or pathologic conditions can impair different reproductive phenomena like the implantation process, the growing of the endometrial line, and also the evolution of the pregnancy. Okay, so my topic, I'm going to talk about different pathological situations and how can we management by hysteroscopy. And so we start from the cervix. In the cervix, the inferior part of the reproductive genitalia. So here I show you an ultrasound scan with the uterus. This is the fundus, of course, and this is the cervix. So here I show you an accumulation of mucus and menstrual blood in the cervical canal, and that reflux until the uterine cavity because a cervical stenosis. In this case, the cervical stenosis is conditioned by a cervicitis, by inflammatory process. But most of the cases are related to surgical etiology, like conizations, trachelectomies, any procedure inside the cervix that can stenose the cervix. As you can see here in this other slide, you can see the external os is practically, there is no external os, as you can see here. So in these two situations, is a good indication to use a resectoscope to increase the size of the stenosis and to get the uterus more permeable to let spill out all the secretions, the menstrual secretions, because the accumulation of menstrual secretion inside the uterus create an toxic environment for the embryo implantation. And also, we need to know that this can make very, very difficult the embryo transfer process. Okay, so here we are using in the inferior slide the resectoscope. We remove a lot of Nabotian cysts that was created because inflammatory reaction there in the cervix. And this is the final view of the cervix and how we increase the size of the cervical stenosis. In this particular case, because it's a previous surgery, we have a fibrosis ring here, a scarring ring here. So normally I prefer to resect this kind of fibrosis to get permeable the cervical canal. We can accelerate because the time here I already resect the fibrosis, and normally in this particular case we use some kind of device, as you can see here, like a cylinder, to maintain permeable the cervical, the internal os until the healing process is complete. Okay, so we remove after a month, and then we proceed with the preparation for the uterus to make the embryo transfer. So it seems like a difficult embryo transfer can make that you waste one out of 4 embryos in viable embryos to implant. Okay, so it's important to know about this. If we go upper in the uterus, we can find the isthmus area. The isthmus area have the typical cesarean section scar, as you can see here in the ultrasound. So the cesarean scar have 2 problems in the reproductive process. One can be the accumulation of fluids and secretion in the niche. So create inflammatory process inside the uterine cavity that impair the implantation process of the embryo. The behavior is like an almost like an hydrosalpinx. Okay, if the niche is too big, and also can make very, very difficult also the embryo transfer because change the angulation of the cervix and change the trajectory of the cervical canal to pass the cannula to introduce and put the embryos inside. So we normally correct this kind of situation with the resectoscope, as you can see here. And we see that the correction of the isthmus cell can suppose an increase on or restore the fertility in 50% of the cases, and also solve the gynecological problem that the patient can have, like abnormal uterine bleeding. Okay? So in the cavity itself, we have the most most of the pathologies are located in the uterine cavity, of course. So in the first slide, I show you some videos of myomectomy. This is a simple myomectomy here with 5 French scissors. We normally perform this kind of surgery without, or we try to avoid the use of thermal energy inside the uterine cavity because these patients have a reproductive purpose. So here we can see how we detach the myoma from the funded area. Okay, and in this other slide we use a bigger size scissor to enucleate all the myomas from inside the uterine cavity, as you can see. And after that, we use the tissue removal system device to extract all the myomas from inside the uterine cavity. This is a very good complement to use the scissors with the tissue removal system to approach these kind of cases. Is very, you can see the scars after the myoma extraction. So the effect of retrieve the myoma from inside the uterine cavity suppose a doubling in the pregnancy rates, of course, and also reduce the miscarriage percentage. So it's important to approach them. There's no discussion about it. So this is another pathology situation. This is a uterine sectum. So here we can see two kind of situation. This is a partial, the upper video, and in the inferior side you can see a complete sectum until the cervix. Okay, so this is nowadays we have a big debate about the use of this kind of surgery to correct the uterine sectum to improve the pregnancy rate. But in our department, we have very good results because we have a lot of experience doing this kind of surgeries, and the results in terms of pregnancy are definitely better than if you do not correct this. This kind of pathology situation is worse. The evolution of the pregnancy are more related also with abortion. So if you treat this kind of sectum, you can reduce the abortion rate. Okay, now we can see the final view of both cases is almost the same, but here in this inferior, we sometimes treat the cervical part of the sectum also. Okay? But if you only treat the funding area, it is most important for the implantation process, for the pregnancy, so it will be fine to only correct the funded area. Okay, this is another pathological situation that we deal frequently. This is a T-shaped uterus, the inferior one. This is a particular case are related with adenomyosis. This T-shape is secondary to adenomyosis. So here you can see the morphology of the uterine cavity. This is the uterine walls are bigger in size. And here you can see a small cystic area represent adenomyotic lesions. Okay, so there's no discussion about the treatment, the surgical treatment of a T-shaped uterus to increase the prognosis of the patient. And in adenomyosis, this is a very challenging disease with a wide spectrum of alterations in the uterus. So normally you can see these kind of lesions like cystic lesions like here, or solid lesions, or more generalized lesions that involve all the uterine wall like here. Is more difficult, more challenging to treat. So normally we prefer to treat these kind of lesions, the cystic lesions that are near to the uterine cavity and near to the endometrial line, as you can see here in this surgery. For the solid lesions like this one, There are papers that describe the benefit to treat with the resectoscope lesions less than 1.5 centimeters. So they try to remove by resectoscope the solid lesions. We personally do not prefer to do that because we think that the use of thermal energy inside the uterine cavity can create more problems than solutions inside the uterine cavity. So we will show you later some pictures about the use of thermal energy. Here you can see the cystic area was removed completely. You can see the endometrial glands inside the uterine wall. This is a typical adenomyotic cyst, and we increase the size of the uterine cavity. Okay, this is the final view. In this particular case, I normally put a balloon inside to maintain the shape of the uterus after the surgery until the healing process is complete. A few words about the PRP. The PRP have nowadays two indications. The main indications will be for a thin endometrial line, an endometrium that doesn't grow up too much. This is an indication today, and the second indication can be after a correction of Asherman syndrome by hysteroscopy. So you can complement the surgery with the use of PRP with the intention to concentrate all these growing factors in the pseudoendometrial line. As you can see here, we use an egg extraction needle to put the product, the PRP, in the pseudoendometrial line, as you can see here. So this kind of treatment can improve the pregnancy. Now there are data, there are centers accumulating data about the use of this, but it seems like it can increase the pregnancy rate. Okay, so our philosophy to work inside the uterine cavity is to avoid the use of thermal energy inside the uterine cavity. There's a lot of papers that relate the use of thermal energy to the incidence of synechia or healing problems inside the uterine cavity. So here, for example, we have a patient. This patient is a T-shaped uterus. This patient was treated by hysteroscopy, but with the use of energy. You can see these black spots there in the uterine wall. This is typical after the healing process when you use a lot of energy inside the uterine cavity. You can see these black spots. So the endometrial sometimes doesn't grow very well in these uterine walls. Okay, so we have seen this kind of problem in several cases. So that's the reason why we normally try to avoid the energy inside the uterine cavity. We perform lateral metroplasty, and we continue with the fundus, as you can see here, with the use of scissors, only scissors. And you can see here another scarring tissue in the fundic area. Okay, this was created because we presume that was created because the use of thermal energy inside the uterine cavity. So now both laterals and also the fundus area was corrected with scissors. You can see the black spots here. It's typical from thermal energy. Okay, this is the final result of this particular surgery. Okay, so this is more examples of our findings of after a patient that was treated with thermal energy. You see again the black spots here during the healing process was created in the uterine wall. This patient have adhesions in the funded area also. This is a very very bad scarring tissue in the fundus because create a lot of fibrosis like this. Again, the black spots there. So it's difficult, a good endometrial growing in these fibrotic areas. Okay, so you must pay attention to about the excessive use of energy inside the uterine cavity because you can have another problem. So, in our opinion, it's better to use cold techniques inside the uterine cavity, as you can see here in the upper part of the uterus. We prefer to use the Betoki with the small scissors and also the tissue removal system device. Okay? It's called instrument to work in the funded area. And for the cervix and the isthmus, we definitely use we can use freely the resectoscope. So I'm going to share to you my personal concept of fertility enhancing intrauterine surgery. So we have 3 cases I want to show you here. This is the first case. This is the MRI and the ultrasound of this particular case. You can see deep osteums. This is typical for a T-shaped uterus, a narrow cavity with deep osteums. Okay, so with drainage and a small adenomyotic lesion in this part of the uterus, you can see here. And with the MRI, we need to guide the surgery with the use of image. In this particular case, the MRI show us information about the uterine walls. You can see in the upper part of the uterus, this small cystic area represent adenomyotic lesions in the upper part of the uterus. In the fundus, you can see in the longitudinal view another big lesion in the fundic area. Okay, so here, for example, in the left lateral wall, we can see this cystic area. Okay, you can see this brown tissue represent glands inside the normal endometrial tissue. So again, here we have another one. So this is cystic adenomyosis. So we remove these kind of lesions. Okay. This is normally as we approach these particular cases. Okay, and also we need to check the fundic area because in the MRI we have another lesion in the fundus. This is the residual tissue after the excision of all the lesions inside. Here you can see this is, you need to pay attention about the colors of the tissue, the consistency of the tissue. These are clues, and of course, with the help of the image, as you can see in MRI, we can detect, we can treat selectively the lesions that these kind of uterus have. This is a big adenomyotic cyst. Continue until this part of the uterus. You can see this is all the cysts opened. And finally, we treat the final lesion in the right corner of the uterus, as you can see here. We know the lesion was there because we use the MRI, or you can use also the ultrasound to guide the surgery to approach this particular case. So now we have a better and bigger uterine cavity with a metroplasty. The T uterus was corrected, and we reduce a lot the amount of adenomyotic lesions inside the uterine cavity. Definitely, this will improve the prognosis in this particular case. This is another case. You can see almost a normal cavity, small polyps here. This procedure was done during an ovarian extraction at the same time. Okay, so the endometrium was high, so we need to aspirate the
I kindly
endometrium.
request you all to please keep silence.
We aspirate the endometrium to get more vision inside the uterine cavity. This is image of the ultrasound in this particular case.
Please
This is
keep
a longitudinal.
silence.
longitudinal view in the funded area in the posterior wall, we can have a lesion here. This is a small myoma. So we clean the cavity again and we try to find the myoma here. As you can see, this is the tip of the myoma, okay, in this particular area. And we know that the myoma was there because we have the information of the ultrasound. So with the use of scissors, we enucleate completely the myoma and we extract the myoma. So we continue working inside the uterine cavity. We put the myoma again inside the fovea to continue with the surgery. And we need to approach the funded area because this is the transversal view of the funded area. You can see how the endometrial line is divided in two zones because the fundus is
Hello. I request you all to please keep silence.
Okay, so this is a funded myoma in the center of the uterine cavity again. So we extracted,
Especially the last people, please keep silence.
and we have another myoma. We also extracted. You can see a bigger cavity without the myomas. And finally, we find another small myoma in the anterior part of the uterus. It's not important, but we also extracted. The most important was both funded myoma that we extracted. Okay, and this is the last case. This is a case that I like to show very much because this is a typical pure uterine factor. Okay, so here this is the medical history of this particular patient. This is a young lady with treatment in another center. So she started the treatment in this year. She performed an XC cycle and transferred 2 day 3 embryos with a negative result. Okay, so because the negative, I think in the other center they practice hysteroscopy surgery because of T-shaped uterus. Okay, after the healing process, they transfer again 2 frozen embryos. Okay, and the result was negative. In the next year, the patient transferred with another XC cycle, another embryo, in this case, a blastocyst, with a negative result also. And in this another year, she performed because I think the approach of this case was think about the embryos. Okay, so they perform 3 XC cycles to accumulate embryos and do a PGD. Okay, so after the PGD, the patient have 2 normal embryos. They perform an diagnosed hysteroscopy, was normal, and they transfer one of the embryos, was a negative, and again in the next year transfer the remaining embryo. So the patient don't have any result after lot of embryos transferred inside the uterine cavity. So we check the patient, we check the MRI image. So here we can see a lot of details. Okay, so we can see adenomyotic lesions, we can see myomas here, and this is a finding during the exploration. This is a false root in the middle of the cervical canal. So we negotiate the false root, we deal with this, and we ingress inside the uterine cavity. You can see here the uterine cavity is quite normal, but we have the information of the MRI to know how to treat this patient. So later we will deal with this false root. So this is the first lesion here in the left corner of the uterus. You can see this cystic lesion here is this one in the MRI. This is an adenomyotic cyst, so we remove it. We proceed with the myoma in the other lateral wall of the uterus. This is a type 3 myoma. Okay, I'm going to accelerate because the time. This is the extraction of the myoma. So now we solve two problems. And finally, we need to approach this big adenomyotic cyst here in the posterior wall of the uterus. Okay? You can see how the chocolate fluid is coming out through this lesion. So we clean this area and we drainage the cyst, and also I prefer to resect only the borders of the cyst, only the borders, and let the endometrial patch that you can see here in the fundus exposed to the uterine cavity. This is how I deal with these particular lesions. This is the final view, the fovea of the myomectomy in the right side, you can see here. And the adenomyotic lesion drainage with the border resected with the scissors. Okay, and we cannot forget about the embryo transfer that will have this patient. So we need to treat also the cervix. So this patient have lot of pathology condition inside the uterus, have myomas, have adenomyosis, have problem in the cervix. So we try to improve this particular uterus. This is a typical pure uterine factor. So we resect part of the false root to facilitate the embryo transfer in the next cycles. Okay, so this patient get pregnant after our first embryo transfer. So this is a very good solution of this particular case. So you must pay attention to the image, because if you pay attention to the image of the uterus, you can find some problems in the uterus that you can solve by hysteroscopy. So to conclude, the use of ultrasound and MRI is mandatory. It's mandatory and is very helpful to approach these particular cases. Okay, so if you are conservative with the endometrium, and that means do not use with excess the thermal energy inside the uterine cavity, you can have a better result in terms of reproductive outcomes. And restoring the uterine anatomy or the uterine cavity, maintain as a normal shape, normalizing all the aspects of the uterine cavity, we can increase absolutely the reproductive outcomes. And most of the IBS specialists focus their attention in the embryos. Do a PGD, I don't know, treat better the embryos in the culture media and whatever they do with the embryos. But sometimes the problem in this particular patient are in the uterus. So you need to pay attention again to the image, because sometimes the solution is there and is relatively easy to treat. Thank you so much.
Hola, Norman. Hola.
Hola,
Pues
hola.
por primer lugar,
Espero.
soy doctora
Sí,
Sharayu.
mucho gusto.
Bueno, mucho gusto y enhorabuena por tan presentación muy informativo. Y quiero decir enhorabuena y agradecerte desde corazón. Nosotros estamos muy encantados de tener a un profesor con tan experiencia. Y esta presentación ciertamente ayuda muy bien para tratar los pacientes de infertilidad. Soy doctora Sharayu, trabajaba con doctora Juana Crespo en el IVI por 6 años.
Oh, Oh,
Sí,
oh,
y ella
oh.
conocerme bien. Bueno, soy desde la India y ella conoce por 6 años y es una experiencia muy buena por trabajar en Valencia en el IBI. Y estoy muy
Oh,
encantada hoy para tener un señor con su equipo y en el Sushrutee. Bueno, y ahora quiero hablar en inglés por todos los gentes que no tiene una duda.
yeah,
Y,
yeah, yeah. Perfect.
okay, so he is here ready to answer your questions. If you have any questions, then you can ask. And I have told him that we are very lucky to have very experienced person today, and his videos and information and this presentation will be really helpful to treat our infertility patients, and it will be helpful in our consultation also. Well, if you have any doubts. Bueno, Norman, me tiene una duda que ¿cuál porcentaje tiene ahora con donación de ovocitos y acumulación? Bueno, una diferencia entre donación de ovocitos y acumulación de ovocitos. ¿Cuál es tu recomendación en casos avanzados?
Oh, okay. So, in egg donation program, you must know that I'm the surgeon here. I'm the surgeon. Normally, I do not perform IVS cycles normally because I have a lot of surgical activity. But I can tell you about the numbers. Okay, so in egg donation program, we have already more than 80% of successful rate. Okay, in egg donation.
Vale.
So normally, I don't know about your question. The bad cases are cases as you can see in the MRI or the image ultrasound, for example. So if the uterus have lot of problems that you can solve by stereoscopy, as you can see here, the prognosis even with own eggs is very good. It's very good because practically this is the cause that the patient do not get pregnant because of lot of problems inside the uterus. So if you solve it and you see a lot of problems, you can have a very good prognosis in terms of pregnancy. But the problem is when you transfer embryos, and in the ultrasound and MRI you don't find anything. You don't find any lesion, you don't find any myoma or anything to treat. So this is a very challenging cases by the surgical point of view.
Okay, thank
Maybe you need to pay attention in other way, like the embryos or something like this.
Okay, thank you and thanks a lot for this answer also, and we are for very informative lecture. Thank you very much, and thank you to your team also.
Thank you so much, and thanks for your kindness word, and thanks for inviting me to participate in your wonderful meeting. Thank you so much.
Thank you.
I will tell to Juana about you.
Bueno, या बर हे तुला परत तिथे यायला पाहिजे म्हणून थँक्यू
Thank you so much, sir. Today we had an opportunity to hear your thoughts, and this will surely be going to encourage us in our future events. Your thoughts have enlightened our minds and have shown us a new path in hysteroscopy. Your insights and expertise made a significant impact, and we are grateful for your valuable contribution. Thank you again for sharing your knowledge and making our event a success.
So I had been following his videos for since long time. I have seen the basic things during the implantation and what is the difference between that. So he has explained me in a very particular manner that whatever you do, see by your eyes. Okay, so I had been there since so many years, since 2-3 years. I observe him how he does with the cold Caesar. He has developed so many things with that. How to use the cold Caesar means simple Caesar. हिस्टोस्कोपी मैनेजमेंट में उस बंदे ने फाइब्रॉइड्स भी इतने सुंदर तरीके से इवैक्यूएट किए हैं. सब म्यूकोजल फाइब्रॉइड सपोज टू बी द मीन्स वेरी डिफिकल्ट. बेस से कैसे निकालना है? Most of the times I have seen the people who are means using the energy source with the resectoscope. He has shown me both the differentiation when you took the patient for the implantation purpose or for the infertility and management. After that, the blood circulation and the epithelialization of the endometrium, how it works. So at that time I decided I will definitely show his skill. And yesterday what we discussed regarding the Asherman syndromes, that you will definitely come to know how cold Caesars are better than the energy source when it comes to the management of the endometrium. And when we should use, that's why Pawan sir said, unless and until there is a hyperdense fibrosis, do not use the energy source. That's why we did all the surgery of the Ashermans with the cold Caesar. So that just I want to add, nothing else. And I'm very much thankful to Dr. Norman Gomez for this, who has accepted my invitation just within a second. And he said, yes, of course, Priyanka, I will do it for you. So thank you so much, Dr. Norman Gomez.